So I would like to ask Yves to give his talk about how to plan your intervention based on angiography. Very important. No? Can we rely on plain angiography?
Yeah, can we rely? No, what we are seeing was more interesting than what I will present. So give me my... I click? Ah. Okay, can we play on plain angiography? I can answer now very quickly. Of course not. So, no, this. This. No, I don't know which. This one? No. There? So I made some archaeology. It's a paper of 1991. I was already stenting patients, with a paper dedicated to limitation of coronary angiography, an underestimated problem, still underestimated today. At the top, you see a phantom field of contrast. And what you can see is the vessel edge are not sharply demarcated, but there is at the periphery, there is what we call a penumbra or edge gradient or border zone of less radio density. This is mainly related to the fact that close to the wall, the thickness of the contrast is less than in the middle. So we cannot change that. This is, and at the right, here, you have this curve crossing the vessel from one border to the other border, and you can exactly see what I said. Here you have a lot of contrast, a larger diameter. Here, only a few contrast here. And this is increasing this picture. What is used today for QCA is there. S, which is the point of greatest slope in the edge gradient. So the greatest slope is there. But there is contrast here, beginning at E or at F. F, the point at which a theoretical edge function best correlates with the observed density profile. So it's clear that we can use F, but how to do that? And the computer, is much easier for the computer to choose the edge. S, point of greatest slope. So I want to explain a lot of this. You have many other factors that change the vision of the angio. A lot of distortion because the X-ray are dispersed, and for example, you have also a photon percuting an electron, creating in two directions, one electron and one photon. This is well known. This is complex and probably not interesting for us. So limitation caused by biologic variations. The angiographic image and the quantitative measurement derived from it are influenced by many biologic variables. First, the variation in contrast medium concentration. In addition, pulsatile pressure may contribute to periodicity of arterial measurement. 5% variation in diameter of 3 to 4 millimeter epicardial segment. This is not nothing. Vasodilating effect of dye was known with the dye we were using a long time ago, and injection of the contrast per se. We increase the in lumen diameter of up to 5%. During the later part of injection, contrast medium is also filling myocardial capillaries, small adjacent branches, and sometimes when vasa vasorum, when the vessel is atherosclerotic. Variation of coronary vasomotor tone can be controlled by, in our place, in anesthesiologist. Finally, motion blurring can result from the movement of coronary arteries. So the angiography is far to be perfect to describe all the complexity of the bifurcation, of the coronary angiography. Visual versus, this is very complex. Just tell you that, I said that already this morning, you see the lesion tighter than it is, compared with QCA. So QCA is giving a better analysis of the percentage of stenosis than lower, than compared with your eyes. And we did this experimentation also I remember, in a bifurcation club. Patrick Sorois bought some images, and we reproduce absolutely the same. We see the lesion tighter than it is really. So can we rely on plain angiography, only using your eyes? Of course not. So coronary bifurcation, just to remember you, that we have coronary branching laws. I have said that, you have seen that many times today. But I think this sentence is interesting for me. Physiological organization, like gravitation, is a stubborn fact, you know? And it is one task of theoretical physiology to find quantitative laws which describe organization of its various aspects. So there is an organization of distribution of blood in the myocardium, and this has to be found and followed. So these are the several possibilities to analyze the branching of a vessel. The oldest is the Murray, which is forgotten today. Second was certainly area preservation is known for valve, for example. But Uokasab Finney's law was followed Murray, which is saying that this is a fractal, repeating the same scheme from proximal to distal, linearly, as it is here. This is Finney. And today you have to consider that probably Uokasab is the blue line here, is very comparable to Finney's law when the two distal vessels are very different in diameter. So this is the same. Yeah. So this is the Finney's law. He measured all the bifurcation here with intravascular imaging, and he found this relationship with the ratio. I don't have the. Yeah, he measured the ratio between the proximal segment and the sum of the two distal segments, 0.67, and it was measured on all of this. Was it 300 measures? And you can see 0.66, 0.67, 0.69, but really very reproductive. Finney's formula. The mother equal the daughter, the two daughters multiplied by 0.67.8. And following this branching law, Ghassan-Qassam rebuilt completely mathematically a coronary tree. Of course, this is a bit heuristic, but this is explaining you how it is and why it's working. So the coronary tree is a pseudofractal object with self-similar reproduction of bifurcation, smaller and smaller. But similar is not identical, like Mandelbrot fractals. All the bifurcations are not the same. The principle is the same. And reproduction is not indefinite in coronary arteries. On the contrary of Mandelbrot, you can use these fractals, you will spend a day to see. The fractal number proposed by Finney, 0.678, is invariable, I said, and the meta-analysis of Taylor and Morris convinced me that Uokasab formula is adapted to all bifurcation and even trifurcation. And I have not verified recently, but a few months ago, I verified that this calculator is still available on internet. So if you have a photo, you have a few seconds. I can give you later if you want. And bifurcation QCA. So we introduce the use of QCA. It's not so I don't think, maybe I'm wrong, but I think it's not common to have an adequate dedicated QCA in a cath lab. Normally, it's coming from the core lab of the research center we have. And I think we need to have this kind of QCA inside the cath lab to take the best decision. In Massy, we have in the cath lab early steps, In 2006, in PCR, so the club was founded. We were working, I proposed this study on quantitative coronary angiography for bifurcation lesions. So I introduced this. It was led by Alexandra Lansky and Marie-Claude Maurice. And this is an example of what was done at that time. You see the line, the red line, is linearly decreasing of diameter from ostium to apex. This is what you see here. If you change the length of an analysis, for example, there is a lesion there. So you change the analysis, you go down. Now the curve has changed. You know, and if you do a third time, it will change again. So this is not reliable. And this was, unfortunately, was in this paper on quantitative angiographic methods, published by Alexandra Lansky, 2011, but was not 2009, and it was not the good option. So I will skip this one. We had in 2000, inside our cath lab, one of the cath lab, we had this software produced by General Electric. And you can see that this one took a linear decreasing of the diameter from proximal LED to distal LED and proximal LED to diagonal. This is not true again. And what is important is, maybe you can copy that, or we'll find it probably, recommended projection for bifurcation QCA. To analyze bifurcation, you have to see the bifurcation. So okay, I don't go in detail on this, but you will find it easily. After that, we try to work more seriously on what to do. And what you see at the bottom left here is proximal LED to distal LED. And you of course, you have the red line, which is not useful anymore, but you have this reference curve, which is step-by-step, decreasing step-by-step at each diagonal. Sometimes the curve is a bit descending because we are not taking into account very small vessels, but they are there. And now we are proposing for the 3 segment of a bifurcation, a diameter, and also a degree of stenosis, a true one. So this one, again, this is the curve proposed by Alexandra Lansky. So you see that the stenosis degree are completely wrong if you go 59%. If you go with the 2-step, you have now 50%, which is maybe not to be treated. This has been reproduced by Phantom, and so this is, you can follow this. And now we have to use again a Phantom on the left, which shows, we compare the QCA, the OCT, and IVUS. On the left, this is MLA. Of course, you are not QCA here. You can see that OCT diameter is reproducing the Phantom. On the right, by diameter, IVUS is too big by 8%. I think this is important to consider because I have seen in China 1 or 2 cases, Xiao Yongchen asked these fellows to present that, representing coronary rupture or perforation. So this is maybe related to the more aggressive use of IVUS data, not OCT. And when you use only the minimum lumen diameter, here you can see that OCT being the rule, IVUS is still oversizing by 9%, and the most important, QCA is undersizing by 5%. So a solution to our problem is undersizing by 5%. Okay, each segment, you add 5%. It's not perfect, so it's not perfect, but this is something we can use. 3D QCA, so after that, the movement was launched, and we saw a lot of improvement. 3D QCA with two projections, and you get what you have on the right. 2D, which is very interesting, but probably I've seen that in the cath lab, for example, in St. Louis with Jasvinder Singh. He's doing that in the cath lab. He has the angio with the QCA, and he has OCT or IVUS. He can combine both. He has facing a vessel which has now good diameter and lesions that can be analyzed. In vivo comparison, I'll skip this, is a bit complex. So my comment is QCA is undersizing the true diameters of 3 segments of the bifurcation. So we have to find a solution. I propose the 5%. Some Korean colleagues in a trial that I will show propose to have a correction which is increasing with when the diameter is decreasing. So it's 5% for the left main, it will be 7% for LED, a diagonal will be 8%, and probably a very small branch, 10%. But we don't treat these lesions. So ABC, the second bifurcation dedicated QCA consensus was done by Carlos Collet. Now he's a leader in this kind of topic. And we changed the description of the different segment. It was 12, now in 6. This is dedicated to core lab analysis for trials, not for what we are doing in room. This is was added again by Collet. Now they added quantitative angiography to get FFR coming from angiography. So this is, in some centers, this is working, like this. And of course, it's not frequent in every cath labs. So intravascular imaging versus angiography guidance for bifurcation treatment. This is the recent European guidelines telling that intracoronary imaging guidance by IVUS and OCT is recommended when performing PCI on anatomically complex lesions, in particular left main stem, true bifurcation, and long lesion. That's a recommendation based on many trials, not always, the oldest is 14 years, so imagine. So yeah, they can be discussed. And the consequence, not yet in France, the consequence is supposed to be reimbursement of intravascular imaging. In France, this is not the case today. So if it's not the case, you have the problem of cost effectiveness. In some countries, the patient pay for the OCT. In my country, this is strictly forbidden. So we have the trial probably was part of the recommendation, the guidelines, because it was dedicated to bifurcation. This one maybe is the only one by bifurcation, not only including some left main. And you can see that the MACE with angiography guided are higher, are bigger, 14.1 versus 10.1 as 2 years, is bigger in the angiography guided. Angiography guided. I'm not speaking about QCA guiding that I was discussing before. So I have something to say about that. So if you look at the previous paper of this October trial, you have a protocol paper. It's published normally in the secondary publication. And this is the recommendation to how to use OCT for OCT guidance at the top. And at the bottom, you have the recommendation for angiography guidance. This is standard guidance. No five tables. No. So no one was speaking about any modification of the QCA. Standard guidance. So of course, when you compare standard guidance, you know, a small car with a Rolls-Royce, there is a big difference. No. Intravascular imaging now, intravascular imaging versus QCA guidance. This makes a difference. We don't have a lot of publication on this. I will show one, which was in the same presentation in Amsterdam, I think, in the European Association in September, was 3 years, maybe more. This paper is coming from Korea. Quantitative coronary angiography versus intravascular ultrasound. You know, this is exactly the copy what we have heard. Guidance for drug-eluting stent implantation, GUIDE DES. This is the biggest trial in number than the one of of October. And they had, at the beginning, in the preparation paper, protocol paper, they generated an hypothesis. Visual guided PCI remains largely unchanged over 40 years. As I told that already. Despite many limitations, we hypothesized that QCA-guided strategy, with incorporation of lessons learned from the IVOS studies, may help to optimize stent deployment and offset the benefits of IVOS guidance. This is a theory. This is what they want to demonstrate. So the lesson learned from the lesson learned are there. OCT gives the true diameter, IVUS oversize, QCA undersize. Other corrections proposed by Mayara can be bigger than 5%. I told you. Use dedicated QCA, better in CATLab than in CoreLab, because it's here. And to reach a corrected diameter, you need a balloon. After that, you have the diameter. Now, you have to put the balloon and the stent at the diameter you measured. Go to 24 atmosphere immediately without thinking is wrong. Inflating 10 seconds, what we hear in the meeting. They say on, and 5 seconds later that we hear the click. This is also nothing. So you have to take into account the curve of pressure diameter that you find in the box of the company of stent. You have to inflate 2 times at least, because the balloon is not completely defolded at the first inflation. And a second point, also from French study, the time is also a factor, and we discovered that the balloon is not only elastic, which is its function, but also plastic. The balloon increases in diameter with the number of inflation. You will find that in a good paper, Polish paper, Skowronski. Puff injection is a solution to say that the stent is on the wall. Not difficult to do. And this, we have the result of the trial, the Korean trial. This is not dedicated integrally to left main, but bifurcation, even not only for bifurcation, but total of bifurcation is more than 70%. And these are the results. Absolutely no difference. Future. Of course, we have only one trial. And I don't want to tell you that don't use OCT. If my government give OCT, we will use it. But the cost in France is 1,800. So it's, if we have to pay from our pocket, we won't treat the patient with aortic valve and so on. So now the future. People from this basis, Korean people, are working on AI-based automated QCA versus OCT-guided PCI, flash trial, 400 patient both group. There is nearly not a difference, except on the right here, you have more malposition in the group treated, guided by the QCA than in the OCT-guided PCI. But the mortality and every other strong factor are equal. Thank you very much.
Thank you, Yves. So, comments, questions? The truth is that we are still relying on angio mainly. We are relying on angio mainly in our daily practice. And probably we should implement more and more intravascular imaging, whatever it is. The problem with the OCT, I think the only one is the contrast use, and maybe the companies should do something just to improve this one, because 2 runs or 3 or 4 means these are more and more contrast, and the patient with the renal dysfunction have a problem with this. So, what do you think will be the next step in real life?
So, I think this way of the QCA guided, I hope will be, other trials are going. will be used in, and compared with the performance of OCT. You see, for me, I'm always a bit afraid by the 8% of oversizing of IVUS. So I hope we will have time to develop that. Not me, but people are develop that and having trials. But another solution is here, is coming in our group. We are the owner. Interventional cardiologists, we are the owners of 3 CT scans. So with a CT scan, you know, it's 3-dimensional. So you don't have the problem of sizing. Of course, the patient has to receive nitrate and so, but we will have probably also to compare that with systematic OCT. And the most recent kind of CT scan, they will give us even more information on the nature of the vessel, of the lesion. And maybe in 1 year, 2 years, patient will go to CT scan before going to PCI, not systematic angio. Thank you very much.
So Eve, I have a question. So QCA is all computer generated on angiography, right?
Yeah.
So there may be some situations where, for example, straight segments, etc., since the correlation between QCA and OCT is close, there may be some situations where QCA is good enough, you don't need intravascular imaging. Because the correlation is so much, and you know, you're not
but
relying
QCA, you know, the QCA is the at the position, the limit of the vessel,
Right.
at the position when the contrast is going quicker. You know, you have seen that the picture at the beginning. So I think this is important to remember that there is some contrast outside. This is chosen because the computer is see better the profile of the vessel. But I can say a word that, but Korean people are very active, and there is a software which will come. I hope will be, their objective is certainly commercially to give this in all the cath labs. That will be fantastic. And after that, we will have enough centers, enough group to work on this to compare with intravascular imaging. This is not against intravascular imaging. I'm thinking of countries that where people cannot be treated of this disease.
Right.
That's very important.
Okay, so let's move further. So intravascular imaging in bifurcation treatment in left main.
Once more, thank you very much for inviting me, giving the opportunity to share my experience on intravascular imaging. Just to comment all of these very nice presentations did earlier, the last great presentation of Yves, I will tell you, in general, we are not the thinkers, we are watchers. We need images. And of course, we can build our action on numbers, but without pictures, without images, we are blinded. So therefore, I truly believe that intravascular imaging will be the first, the most effective tool or tools in contemporary interventional cardiology. However, we can implement let's say the comparisons and relations between so-called sophisticated angio, let's call it like that, with the difference which is systematic to intravascular say measurements, just to understand more and to avoid at least for so-called simple cases intravascular imaging. But you have to remember that in majority cases, the morphology of the lesion is a kind of predictor of the consequences and the late outcome of the patient, immediate and late outcome. So therefore, let's think that we are looking for something which will not replace one by another, but rather will be an additional tool and support for our better decision and better results. I don't have any potential conflict of interest with this particular presentation to declare. However, I am still active interventional cardiologist, busy with intravascular imaging since the beginning of my career. That was really many, many years ago. And I would like to start my presentation with this slide showing that was the first slide showing that IVUS guidance can really improve the results of percutaneous treatment for left main. So my topic today is just the area is a left main treatment, so especially distal one. So we have to keep in our mind that this most important part of the coronary circulation should be diagnosed and treated, let's say, parallelly to the importance of this vessel. It supports more than 2/3 of the myocardium. And we know from the literature that we have 10 years follow-up for the patients showing that this effect of the usage or guidance for IVUS it persists for at least 10 years. So it means this investment at the beginning, especially for this portion of the coronary circulation, is very, very, very important. We should keep in our mind. If we are talking about intravascular ultrasound, we have to keep in our mind also the fact that this technique was tested in every possible situation. We were also we tested the relationships between physiological assessment and visual assessment. So therefore, we have numbers which are very helpful for our daily practice. Today we had for example, we had a case where this additional functional assessment of left main properly decided about the optimal treatment of this particular patient. So this is another slide showing how important it is and how was tested intravascular ultrasound for left main, for intermediate left main stenosis. So therefore, this is not just by chance that in the newest guidelines of European Society of Cardiology for management of chronic coronary syndromes, it is stated that this that the IVUS should be considered to evaluate the severity of intermediate stenosis of left main prior to the revascularization. So it was done today in a proper way, as I said. So you should remember, you should keep in your mind this very simple cartoon showing that this is not a matter of 6 square millimeters, which should be a cutoff, yes or not, for intervention. We should remember that we have a kind of gray zone between 4.5 and 6 square millimeters for left main, where if we don't have clinical symptoms, if we don't have a very strong confirmation by non-invasive techniques, this invasive functional assessment is necessary. It was done today very properly. Taking into account the assessment of left main, especially distal part of the left main, we have to remember that we need, let's say, 2 pullbacks. One from LAD, the second from circumflex. I don't want to go into the details, but if you do that with this particular slide, you will discover that the differences in the measurements of most narrow part of the left main and also the ostia of LAD and circumflex artery are different if you base these measurements on one pullback from LAD or from circumflex artery. We should also remember that this pre-procedural assessment, especially for circumflex artery, is very important because due to the Kang's group experience and publications, we know that automatically after crossover with the stent from left main to LAD, we decrease the lumen of circumflex artery. Then we can use this information deciding whether one or two stents technique for left main stenting should be chosen. This is very important. So, as I already mentioned, the most important thing for left main treatment is pre-procedural measurements, both pullbacks, with both pullbacks, one from LAD, one from circumflex artery, showing all of the crucial parts of the left main. Because left main, this is not just a one vessel, but a complex of three vessels interfering due to the, not only due to the angulations, but also due to the atherosclerotic process, which can be discovered and assessed by intravascular ultrasound very, very easily. Based on these results, we can really design a proper protocol for particular patients. I don't want to go into the details, but just to illustrate for you how important are all of these details that we can we have to let's say gather by these two pullbacks. Then, of course, as it was very many times mentioned today, this provisional approach also for left main, it's I would say is optimal at least for 70% of cases. These pre-procedural measurements showing the not only the anatomy before the procedures, but the tests or testing after the first implantation, showing whether we and how could optimize the result. This proximal and eventually distal optimal technique is very important and should be let's say applied to the patients. Especially these two pullbacks are important when we have very complex lesion where there is a real or true bifurcations with the involvement of side branch when circumflex artery is mostly in that position. Here you can appreciate the case showing all of these details which should be taken into consideration in terms of way of or type of predilatation, I mean classical based on balloon or rather more debulking devices, then sizing for predilatation, then for redilatations, and then based on that we have to test the results after first implantation, redilating or they use additional stents in terms of, for example, for edge dissections or intramural hematoma. We have to keep in our mind that based on IVUS, we have some numbers important to assess whether our results are optimal or not. And then I would like to show you that there are some discrepancies between our first experience and expectations and how we were forced to change this approach. On the left, you see the so-called Kang's formula with 5, 6, 7, 8. But remember, this data was based on Asian populations, which are regularly smaller So therefore, these numbers doesn't fit for Caucasian population, and you can easily add at least 2 square millimeters, let's say, expecting potential improvement in follow-up. But if you look that even increase this minimal stent area up to 9.8 square millimeters, still we have some significant, let's say, percentage of the patients with potential problems in terms of late outcome. So therefore, we need to understand, we need to illustrate our results trying to improve that. Here, just a paper showing how important is post-stent implantation IVUS inspection just to improve this area. In this particular, let's say, case which is presented, you see that after good redilatation, the minimal stent area was doubled. That is very, very, very important. And of course, there are some potential complications and problems associated with ultrasound, let's say, imaging, which is called longitudinal stent deformation. It was found in the population of ACCEL trial patients, where in almost 7% of cases this deformation was found, but not in a local laboratories, but in core labs. So the outcome of these patients is very bad. So therefore, we have to let's say assess the final results not only based on angio, because it's not well visible, but it's relatively well be corrected, knowing about this complication. In terms of OCT, we have to appreciate that the resolution of the OCT is much better. So therefore, let's say the images should be much more precise and easy to interpret. However, the depth of penetration is less, and let's say sometimes, especially for first generation of OCT, there was not easy to assess the size of the vessel. These IVUS and OCT differences you can list it here. I don't want to go to the details, but to tell you the truth, that with OCT we have the problem with proximal part of the left main in terms of proper assessment. This is a weakness of the technique. However, today I'm talking about distal left main, which has not this problem at all. Some guys used to say that OCT needs a contrast medium, which is loaded 3 times per, let's say, by 10 cubic let's say, a centimeter or milliliters. But here you can appreciate let's say, the one pullback in a zero contrast OCT performed by a friend of mine, Professor Maciej Lesiak. We did also in our lab. I can assure you that the results are not so bad, I would say. We are able to recognize all of the needed details. So the usage of saline infusion or dextran, it's feasible. We can avoid this nephrotoxic impact of additional contrast medium. But if you look at the precision and details on these both techniques, you can appreciate that this is the truth. With OCT, we see better. This is for sure. And of course, there are some papers, some publications showing that in terms of comparison of these two techniques, OCT is feasible, let's say, giving very important information, and the results in general are let's say, similar. However, we still don't have cutoff criteria which we can really rely on, which, for example, I show you this 4.56 more and less, where and how we can manage with these results. With OCT is not so clear. This is always the responsibility of the operator. But since I would say 10 years, the number of papers, trials, studies trying to use OCT guidance for left main disease treatment is increasing. Here you can appreciate, let's say, a Lemon trial, which was the first trial showing the possibility of usage or utilization of the OCT for left main. However, that was not very big number of patients included in this topic. And since at least 4 years, let's say the study comparing these two techniques are let's say presented very often. Here is one of them. Let's say that the authors concluded that intravascular imaging was superior to angiography for distal left main, with no difference between OCT and IVUS. So what we need right now the numbers. We have to create this cutoff criteria as is already done for IVUS. Here you see another trial showing that OCT is not on a very bad position. There are some superiorities compared to IVUS that we have to keep in our mind. In terms of procedural complications, as you know, with IVUS catheters, we can make more harm, more problems and complications than with contrast or saline infusion. So therefore, there are some proposals in the literature how we should manage and when and which kind of technique should be used for this IVUS diagnosis, for left main disease diagnosis and treatment. However, my suggestion is that we should focus on one which we really feel and have, let's say, a permanent access, just to be expert on that, because this is not a problem to perform IVUS or CT, let's say, imaging. The most important is a proper interpretation of the images and translation of these images into the protocol of the procedure. And I would like to finish my presentation, let's say, reminding you that since 2024, the indication for IVUS and OCT, especially for anatomically complex lesions, particularly for left main stenosis, true bifurcations, long lesions, is recommended as a 1A. So keep in your mind, this is not just a neutral recommendation. This is a strategic one, mandatory for every performance in our daily routine work. Thank you very much for your attention.
So thank you very much, Professor Gil. Any question from the audience? Any comment or remark?
Robert, so everybody knows that intravascular imaging is very important and the results are very good. Why the lack of penetration then in common practice for IVUS?
I have probably the only one and true explanations. We, as a human being, are very lazy. We are very clever. We like to avoid some troubles. In our mind, there is a certainty that we know that angio is not the best, but we can add some information which we get looking at the IVUS or OCT, improving our results just because of this knowledge. This is a simplification of the process, but if you start to discuss, and the problem exists especially in old, very experienced operators, because they used to say, I don't have any complications. My results are great. But you know, these operators, they don't follow the patient. They know only they, let's say, follow up of these patients. I must confess that I was one of the first in Poland who started to treat left main by stents. I had very many hard discussions with cardiac surgeons. They called me mother. How can you do that? That was more than 20 years ago. And right now, I will tell you, I changed my approach because I started to analyze the results. Our results without IVUS, this is disaster. This is against any rational approach. And what I would add to our as obligatory is just the mandatory assessment of at least 1 year results after left main stenting. And without this kind of awareness and consciousness, nobody believes that I'm right, what I'm talking right now. But you know, for half a year, the results after left main stenting are very good. After 1 year, the 1 year is a crucial moment showing whether that was optimal or not. But also for optimal results, you can have complications and MACEs. So this is the problem.
Maybe I could add another reason, which usually is not mentioned in the meetings, in our financial problems.
This is another story, of course. Yeah.
In these expert meetings, nobody wants to mention that, but the reality in the real world of more than 90% of the centers, they are submitted to much harder restrictions.
I will tell you, 5 years ago, I had a very strong discussion with the experts, let's say, gathered by ESC for guidelines. Among others, also this, let's say, intravascular imaging. And there was a kind of story. But you know, if we put 1A, who can afford for that? That was straightforward. So I was surprised that in 2024, they put 1A.
All you tell is very, very interesting. So just to tell you that personally, I don't think we have to go on with nose evaluation of the angio, which is a real problem. Why? Because today, we are not reimbursed, so we cannot do intravascular imaging. But I'm feeling sometimes that after this classification, we will have law problems. I mean, the court.
Yeah.
You know? So my point of view, if you are in a country who have no intervention, who you have no reimbursement, is time to build something, to build trial today to compare QCA, modified QCA, with intravascular imaging. And you have seen that the Koreans are going with QCA AI compared with imaging. And they have seen the result is so-so, the same, yeah, not very different. So I think for the audience, now we have 1A. If you have option to use intravascular imaging, use intravascular imaging.
You
In my
know,
country is, if it's reimbursed, and after long experience in Massy, for example, you remember syntax.
I
In
remember.
left main, the
I
second
remember,
period,
yeah.
left main versus surgery. We were the unique country to be equivalent to
Yes, I
surgery.
remember. Yeah. You built a kind of new approach based on angio and Fine formula, because I remember that was many years ago the main area case, left main bifurcation, and Jean Fajadet did everything without IVUS. There were some questions, probably somebody from America asked, what about the IVUS? We should do that, blah, blah, all of these things. And I remember let's say, the answer of Jean. We in France don't have access to IVUS, but we built our approach based on. Then there was 3 slides showing how you can manage with a good, say, quality angio, a size, how we can, let's say, optimize the result. At the end, there was a slide showing your results, that they were so good without IVUS. I remember that.
Yes, but I think this is for the audience, not for me. I'm retired. Even for you, you are the expert of this. But I'm thinking about people that have no access to intravascular imaging, obliged to treat the left main. You know, so not all the left main are going to surgeon. Some left main cannot be treated by surgeon, like with cancer, with
I
think I am afraid for them.
Yes,
not to go to the court.
In my country, we believe and we try to follow guidelines of European Society of Cardiology, but these guidelines, they are a kind of suggestion without confirmation by law. There is no 100% necessity to use, but in court, the expert can ask you, why didn't you do that? So 10 years ago, we could say because that was not reimbursed. Since 10 years, we have reimbursement in Poland, but the percentage of IVUS is around 20-30%. So it's an irony of life. But in this situation, our interventionalists will be in a very bad position in court. In other countries, we need a kind of substrates or recommendations how we can improve our results even without intravascular ultrasound. For example, these algorithms by AI can be very helpful. Why not?
Zdravenie.
Hello, everybody. Thank you for the opportunity to present today, even online. I'm sorry that I cannot be there with you. However, I will try to do my best, even remotely. So, yeah, I think you can see my slides. So today I have the role of speaking about CT angiography and its role in left main and bifurcation planning before PCI. So an important remark, I am not an invasive cardiologist, however, I will try to convince you in the benefits of CT. In the last years, just 10 years ago, CT was only seen as a screening tool, used to evaluate patients with the lowest risk. Then, with the advancement of the technology, of the CT technology, with artificial intelligence, we started using more and more CT angiography to diagnose our patients and see if they have obstructive or non-obstructive coronary artery disease. However, just in the last maybe, 5 years, we started seeing CT as a valuable tool to actually plan our procedure, and not only our procedure, but our most complex procedures. Not only plan the procedures before the cath lab, but also to use it to guide our PC inside the cath lab. And in the last, again, I say 5 years, both European Invasive Society and American Invasive Society started recommending CT. And you see, they're not recommending the CT angiography just to rule out coronary artery disease, but also to tailor our medical therapy, also to plan our procedures and see what the best mode of revascularization is, if we should do surgical revascularization or percutaneous one, and also, you see, plan the most complex procedures of patients with left main disease and with bifurcation disease. But how can we actually do this? How can we guide our PCI with just this non-invasive tool of CT? You see, CT has this very, very nice benefit that we have 3D coronary visualization. We can rotate our coronary tree and the heart in every way possible, in ways that are definitely not possible in the cath lab, and we can visualize our bifurcations in every way that we want. This allows us also to evaluate the osteums of the coronaries, to see if there are any coronary anomalies, what are the angulations, and to select our most suitable catheters before the procedures. Moreover, we can assess the plaque composition, the plaque characterizations of the lesions, so we can see if it's a lipidic plaque, if it's calcium plaque, how long is the plaque, which I will later demonstrate, I think, how important it is. Moreover, with special softwares not available everywhere, but probably it's coming, with CT we can evaluate the myocardial mass at risk, the mass that is supplied by the specific coronary lesion, so we can assess how large is the mass that is at risk. All of this we can use to guide our procedure in, again, with some specific softwares online inside the cath lab. And if FFR CT is available, we can also evaluate the functional significance of the coronary lesion. As a consequence of all these benefits of CT, a lot of groups try to evaluate the benefits of CT specifically in bifurcation lesions, in these lesions that still have a lot of complications and not so good post-PCI results. So you see there are a lot of studies trying to see how can CT help. And this is a study from 6 years ago trying to develop CT based score for bifurcations to evaluate how much is the risk of intraprocedural side branch occlusion based on CT characteristics. And you see they say that a patient is a low risk for side branch occlusion after bifurcation PCI if the patient has no low attenuation plaque, no proximal calcifications, if side branch stenosis is less than 50%, and patient is with high risk of side branch occlusions if there is low attenuation plaque, calcium, and plaque with more than 50% stenosis. And let's see how this score did. The CT bifurcation score had, I would say, agreeable predictive capacity to predict the side branch occlusion with area under the curve of 0.75, which did better than the RESOLVE score, which is the angiography, completely angiography-based score. However, I am still not very satisfied with this result. And I think something important, this is just my opinion, but something important missing from this score is that they have not implemented the angulations of the bifurcation. And if we look at this work that is almost 20 years old of Professor Vasiliev and Professor Gil, we see that they verified this alpha angle and the angulation between the side branch and the main vessel as an important predictor of side branch stenosis post-PCI. So I think this is a very important missing piece in our evaluation pre-procedurally if the patient is high risk of side branch stenosis. And what better tool to assess bifurcation angulations than CT? I will try to demonstrate that really CT is the best for angulations. So let's see some cases from our clinical practice. First of all, I would like to show you 60 years old male with chronic coronary syndromes, arterial hypertension, known atrial fibrillation, and dyslipidemia. From calcium score, we see rather high calcific burden, mainly calcium lesions in LAD. When we look at the MPRs, nothing specific in the right coronary artery and the left circumflex artery. However, in the LAD, we see lesion that is starting actually from the left main into osteoproximal and proximal LAD. Lesion that is a complex. We can evaluate that we have low attenuation lipidic plaque. We have also calcific plaque. We can very accurately measure the lesion length. And here we don't have any vessel foreshortening. We don't have any angulation problems like we do in the angiography. With the CT, we can measure very accurately the lesion length, just as in intravascular imaging. And here we see from healthy to healthy segment, lesion length of 52 millimeters. If we want to take a deeper look in the characteristics of our plaque, we see our proximal reference diameter, which is with a normal vessel. Then we see the start of this lipid plaque, lipid component, low attenuation component of our plaque in the left main going to the osteoproximal part of LAD, and then this dense calcific plaque in the proximal part of the LAD. As I said, we have this beautiful 3D visualization in the CT, which allows us to have a very nice 3D image of our bifurcation. So here we see we can measure the minimum lumen diameter of LAD of 1.3. We can also measure the minimum lumen diameter of the circumflex. And to visualize optimally our bifurcations, we can rotate however we want. And you see we found this angulation, which is completely impossible to be performed in the cath lab. However, it allows us a very good orientation of how our bifurcation look. Here I speak about the bifurcation of LAD and circumflex. And we can measure the angle, which between the LAD and circumflex is almost perpendicular. Later, if we look at the LAD and first diagonal, here we find again very weird angulation. However, it allows beautiful visualization of the bifurcation with angle between the LAD D1 a little bit more steeper. We can as well measure the minimum lumen diameter of the first diagonal. We can also evaluate the second bifurcation with D2, which is kind of small. And with all this information, we go into the cath lab. Here, I think you can see all the foreshortening, all the overlap between the vessels. However, knowing all the information beforehand, we go into the cath lab with a plan. So first, we started with scoring balloon angioplasty in the proximal segment of LAD, exactly in this calcific lesion that you saw from the CT. Then the implantation of the stent in the proximal LAD, the implantation of the stent, the proximal stent, pot, then drug-coated balloon in the first diagonal, and pocket technique, proximal optimization combined with kissing inflation in the left main bifurcation, with this final result. And then our second case, here we have a 71 years old male, again with chronic coronary syndrome. He went for a CT. CT shows lower calcium score. The MPRs show again bifurcation lesion in proximal LAD with nothing specific in the right coronary artery and the circumflex artery. If we look further in our LAD lesion, we can measure length of almost 40 millimeters. Again, we can take a deeper look at our plaque. We see a high-risk plaque with positive remodeling of our vessel with low attenuation components, so lipid component of our plaque. small calcifications, and we see the most severe part of the lesion exactly at the confluence with the first diagonal branch, with minimum lumen diameter of LAD of 1.6. Again here, the angulation that we found as optimal from the CT was impossible to be performed in the cath lab, but we wanted to look very detailedly at our bifurcation. And we measured the angulation between the LAD and D1 of 52 degrees. So inside a cath lab, we did predilation and then stenting with, you see that the length of the stent is exactly the same as the lesion length from the CT, then post-dilation with non-compliant balloon, and this final result. And the last case is not so typical clinical case scenario. It's a very young patient, 34 years old male patient, that came to our emergency department because he had sharp cutting chest pain during physical exercise that resolved spontaneously after 10 minutes. At the time of the presentation, he had no complaints, but he wanted to check if everything is fine. This was the ECG in the emergency department. However, we decided to admit him and evaluate more. From the laboratory, his troponin was elevated 81 picograms per milliliter, as our reference is up to 14. From echo, he had normal ejection fraction, normal kinetics, aorta, which was with normal size. However, we decided to do CT of the heart with the idea to evaluate the aorta and the coronary arteries and see if maybe there is some acute aortic syndrome, acute coronary syndrome we wanted to check. However, we need to keep in mind that this was kind of emergent patient, so there was no time to prepare him with beta blockers, so his heart rate was rather high. This is the ECG from the CT. So CT is with definitely lower quality. However, we saw that the aorta was perfect, definitely no signs of acute aortic syndrome, a little bit of calcification with calcium score around 60. So this is the CT, again with pretty bad quality. However, we could evaluate this with the cursor that there is only one coronary origin. All coronary arteries are originating from the right coronary ostium, with left coronary artery having retro-aortic course. And even with this low quality, we can see that here at the proximal part of the left main, there is some problems in the contrasting of this artery. So we were just trying to wonder what we should do with these patients when just 5 minutes after the CT, he had again, oh no, I have chest pain once again. And this was the ECG with ST elevations in anterior precordial lead. So after seeing this ECG and again the clinical presentation, I said, okay, probably there is definitely something in the left main of these abnormal coronary arteries. And the patient was urgently referred to the cath lab. And here you can imagine that the invasive cardiologist had the opportunity to know beforehand that this patient has abnormal coronary artery, that everything is originating from the right, so he could focus directly there, even that the lesions were from the anterior wall. So you see, this is what we found, severe lesion in this long left main that has retro-aortic course. And the patient was stented. They also did post-dilation. However, during this very fast procedure, patient had recurrent episodes of ventricular fibrillations, and he underwent 13 shocks to restore sinus rhythm. So you can imagine the urgency of this procedure. However, and the final result was fine, and the patient is completely okay. So, as a conclusion, I would really like once again to focus that CCTA provides an accurate and comprehensive assessment of our coronary tree and especially bifurcation lesions with this 3D visualization of plaque composition and plaque distributions in different angulations. Therefore, the role of CT expands much beyond the diagnosis and risk stratifications of our patients. Comprehensive PCI planning based on CT may have an important role in guiding our left main in bifurcation treatment strategies. And I'm curious to hear your opinion.
So thank you, Nia. Questions, comments?
Congratulations for this excellent presentation, as usually. I'd like to know whether you have also some data or experience on complex PCI in surgically revascularized patients, in patients with bypasses. Because I have the impression that we could spare much contrast, much time, and being far more efficient in this particularly challenging setting.
Yes, this is something that we do. The protocol with previously bypass patient is a little bit different so that we can have all the bypass in acquisition. And I think we have pretty good visualization in these patients.
Actually, sometimes it is easier to do a CT on the patient's post-operation by CT than angiography, definitely, with less contrast. But the protocol is different, just because it requires different synchronization with the injection and the acquisition phases. So it's a little bit different from the standard just for coronaries. Yeah. And for this young patient, I'm returning back because that was a case which we made a few weeks ago. It was really emergency case, and the patient had 13 shocks because in any moment when we passed with the balloon or something through this distal bifurcation of the left main, he fibrillated immediately after the passing with the devices, but finally we succeeded, and Nia was much more categorical about the diagnosis done during this presentation, because she pushes us that we should do something. Actually, this is not because the first sight it was probably that he has a spasm because of the age, 34-year-old. And actually, because of the CT, we were pushed to do something more aggressively. And another point is angulation measurement, because there is no standardized method about the angulation measurement in CT still. And we are evaluating 3 different methods for evaluation of the angulations, and what we learned that practically angiography is very, very misleading. You're thinking that you obtain a very good visualization of your bifurcation, but in reality it's a little bit different. We are in the kingdom of shadows in angiography.
I had a question. This is not bifurcation, but what are your thoughts on planning for a CTO revascularization? And if you are doing that, then what is the protocol? Do you have any experience with this?
You mean after?
No, CTO planning, after you've done the
CTO
angio
planning.
Yes.
We have quite a good number of cases with actually We demonstrated in Warsaw a case with the CTO, which was very interesting because there was a stents implanted in very interesting way, and practically CT is the best for me for planning just beforehand to know where the vessels go. For planning, just to have a clear image what you have to deal on.
And also for in-stent restenosis planning? I mean, if it is a CTO of an in-stent restenosis, is this a limitation? Or with the most modern CTs?
Nia can answer you about the restenosis, because we had a lot of discussions about the restenosis, instant restenosis in CT. This, Nia?
Yeah, honestly, regarding restenosis on CT, I don't feel confident at all. But if there is an occlusion, that is clear. And if there is an occlusion, for sure, instant occlusion, for sure, CT is very helpful, because we should remember the CT shows us not only lumen, but shows us the vessel. So even if there is no contrast inside, distally to the stent, we can still see the vessel wall. And it can still be very helpful to plan our revascularization. Regarding restenosis, probably with advancement of the CT, with the photon counting CT, it would be great. But with what we have, I don't feel confident at all.
The restenosis assessed by CT, it's a little bit play of chance. Still, we will see with we are doing a lot of CTs, and we follow the patients with CT. Now, this is the strategy. We started to follow the patients after PCI with CT and stress testing just for ischemia detection. But we have still not, we are not conclusive about that. We will see, maybe at the autumn of this year, we will have some more statistics, at least for 1 year follow-up of these patients. But we are doing this at the moment.
And final question, I promise. Regarding the CTOs, which criteria do you think is the best to do a pre-CTO PCI CT? For all the CTOs, for a JCTO score 3 or more, like in Warsaw, or if the operator does not feel confident with the anatomy seen by the collateral filling, which criteria do you think is the best to indicate a CT before the CTO intervention?
To be honest, at the moment, I'm keen to all unsuccessful cases to direct to do a CT, just to be sure that on the next attempt, I will have a complete anatomical image about the vessel. This is because we have an opportunity to do that, because Nia is working together with me, and we can do that. But this is difficult to give a recommendation, because it depends on the center capabilities. Just, I don't know, George, what is your opinion about CT planning and CT follow-up, and maybe in failed cases about the next procedure planning with the CT?
This is a discussion that we had for many, many years. And we have to consider, of course, CT has been improved, but 15 years ago it was a considerable amount of radiation on top of another radiation procedure. So the initial standpoint of the bifurcation of the EuroCTO club was that at that time they should be reserved for failures in order to understand the mechanisms of what it is. The other thing that over time we evolved, and today I would say that, and this is for me the most important, because people are focusing on the success rate. Success rate is anyhow high, even in expert hands. City will not improve the success rates, but it will improve the efficiency of the procedure. So personally, I believe it anymore. I was not so much against, so much in favor in the past, but I believe that if you get the information of the city, especially with the new protocols that are existing, that you can go to lower radiations, that it can help on the planning. But if you go and you do 100 procedures with or without CT, I'm not talking the failures, the success rate might be the same. But the economy of the procedure is going to be much more efficient in the city-based planning.
Okay. Valery?
We're doing CTs for some of the cases, especially when ambiguous anatomy, especially the right, after failed attempt. But in order to do it, you should have the CT, station in the CAD lab. Yes. Otherwise, it's not working. And we are working on this. We ordered already. And this is something, and of course, the interventional cardiologist should get some experience and knowledge how to reconstruct it, at least, how to operate with this, even at the basic levels. And this is the conclusion to which we came with Professor Kirova, because we are doing quite a lot of CT for coronaries for different reasons, especially electrophysiology, but coronaries. And we running down the stairs, coming back, see what's going on, and this should be done. And she said, okay, it's the best way is to have the station at the CAD lab, and someone who is a little bit proficient in just, how to say, management with the images.
I forgot one last comment based on what Dr. Gelev said, is that if you have this capacity to integrate the CT within the cath lab, there are also the softwares of co-registration anymore. So it's not about only the imaging, but how you project the CT on top of the angiography, and this might even help even further on the procedure.
So we have, I remember several cases in which we have done right with absolutely unclear course. And when we do the CT, it gives us the, let's say, the support of the knowledge of the vessel course, and that allowed us to be more aggressive with wires. So otherwise.
Okay. So if there is no another questions, thank you, Dr. Mileva, for the nice overview.